All right, let's go ahead and get started. Welcome to today's webinar, Myotonic Dystrophy 101. We're really pleased to have Dr. Cynthia Gagnon here today to present information on myotonic dystrophy, and even more pleased that we're doing this on a day where we get to celebrate myotonic dystrophy awareness throughout the world. Actually, I'm pleased to share that one of the Canadians and participants on today's webinar is the one who created the logo that Dr. Gagnon has on her side right now. We're really grateful for your work, Alexandra Leboeuf, and glad that you won the competition and it gets to be part of this important day. In addition to that, I want to highlight that Myotonic Dystrophy Awareness Day was recognized by the Manitoba government, and you might have seen posts about them today proclaiming September 15th International Myotonic Dystrophy Awareness Day. In addition to that, Health Canada has noted this as an important health promotion day as well. And so with that said, I would like to introduce to you Dr. Cynthia Gagnon. She is a researcher and clinician at Sherbrooke University in Quebec. Dr. Gagnon trained as an occupational therapist and obtained her PhD in rehabilitation at Laval University. She is leading an interdisciplinary research program to document the natural history of the most prevalent neuromuscular disorder in Canada, including myotonic dystrophy and RSACs. She is developing and validating several outcome measures among these populations in preparation for clinical trials. Dr. Gagnon is the leader of the OMMYD International Initiative for the selection and validation of outcome measures in myotonic dystrophy, and she is an investigator of the Neuromuscular Disease Network for Canada and a member of MDC's Medical and Scientific Advisory Committee. We really appreciate your ongoing support and despite competing priorities here today to present on this important topic. Over to you.
Thank you, Mira, for this great presentation. And I'm really glad to be there today on this Awareness Day. Myotonic dystrophy is very important to me because it's been the subject of my doctoral thesis. And I've been very much involved into different patient organizations across the world in disseminating knowledge and helping families to live better with the consequences of those diseases, mainly based on my occupational therapist background, of course, but also on my researcher background. And I'm really glad to be here today. Whoops. Okay, this is my disclosure. And today's objective was really to get an overview of what is myotonic dystrophy, what are the signs and symptoms, what is the prognosis. And really, the main focus of my talk will be about helping you to learn about treatment option, to learn about service provision, and a little glance at what research is being done, what kind of research is being done in Canada. There will be a period at the end for questions. So my talk would be mostly about myotonic dystrophy type 1, because this is where I'm most involved in research and in clinical care, but I will also sometimes overview for myotonic dystrophy type 2. So this is the most prevalent adult onset neuromuscular disease in the world. And what is specific or special about Canada, and more specifically Quebec, is that we get the highest prevalence worldwide, which means that we have a large patient population in regard to our global population. And the thing that is very important there is that we have developed a clinical expertise to address issues related to myotonic dystrophy. We really well know clinically what is myotonic dystrophy. The other important point is that we also have the ability to recruit a large number of patients in a very short time and within a small distance. Like, let's say, to do the type of research that I'm doing right now, I will probably need between 15 to 25 centers across the USA, where I'm only doing this in Saguenay. So you see the ability that we have to address research on myotonic dystrophy in Canada. So we got several research projects, and I will show some of them a bit later. I will not go into detail about the genetic defect, but what is important to learn is that that defect of one gene is really an expansion. So anyone with myotonic dystrophy will have between 50 and 2,000 repetition of what we call CTG repeats. And globally, the more repetition you have, the more severe the disease will be. And also the symptoms will start earlier. But this is not the whole story. So two people can have the same number of CTG repeat, let's say 700, and one can start to have symptoms during adolescence, while the other will start to have symptoms, let's say at 25 or 30 years old. So it's a complex disease, and there's other factors playing into explaining the severity and the rate of progression. So the idea here together is that when you receive your diagnosis and you have your number of repetition, it doesn't tell you the whole story. And maybe your sister or your uncle have less repetition that you have, but they are more severe, they appear more severe than you. So there's other factor. The other important point is what we call in medical language the phenotype. The phenotype is that what a clinician can see, what a patient can experience. So it's the signs and symptoms. So the phenotypic classification is really an important thing when you learn your diagnosis and when you read article about the disease, guidelines. A lot of our patients comes in with different research article, clinical guideline information on the web. And what you need to realize is that if your child has congenital myotonic dystrophy, but you have adult myotonic dystrophy, it's the same disease, but the severity will not be the same and the progression. So generally speaking, we agree internationally onto 5 phenotypes. So the congenital onset is really happening at birth. You got the childhood, the juvenile, the adult, which is the most frequent, where the symptom will start between 20 and 40 years old, and the late onset, which is usually starting over 40. And the phenotype will strongly influence the management, the clinical management that will be given for the patient. For example, at our neuromuscular clinic, late onset patients are followed generally every 3 to 4 years. And in between, they got a call from the nurse case manager, and they fill out a systematic phone interview. While with the juvenile or the adult onset, we see the patient almost every year. So the management is really influenced by the phenotype. And what you see here is the age of onset of symptoms among the different clinical form here in color. So you got congenital to late onset. And what you see generally is that you will, either that you have the late onset or the infantile, you will have probably the same symptoms. So you will have cataract, you will have cardiac problem, you may have gastrointestinal trouble, but they won't happen at the same age. They will start earlier with some of the phenotype and later on with others. Now, before we move on to signs and symptoms, how is myotonic dystrophy diagnosed? And that is true also for DM2. Just for DM2, there is no, to my knowledge, phenotypic classification. But for DM1, how it is diagnosed. So usually the patient comes in, usually from his doctor, if you got the adult phenotype. And what you see here is that this is the first symptom experienced by patients. So it's usually the reason for referral. And most of them for DM1 will be myotonia or muscle weakness. And for congenital myotonic dystrophy, which is the one that happened at birth, it will also be muscle weakness and neonatal issue. So this is the presenting symptom. This is why you will go consult the doctor. For the juvenile and infantile phenotype, usually it's school difficulties that will bring on the initial diagnosis. So you complete a family history and a physical examination that will be done usually by the neurologist or the neurogeneticist. You will do a battery of medical tests depending on the symptoms to see, well, is that myotonic dystrophy or not? And then probably you will receive a electromyography, which is a small needle that is inserted into your muscle. And then we see the electric signal that is sent through the muscle. And then once all of that is done, usually we say, okay, this is myotonic dystrophy probably. And then we go to take a blood sample so that we can send it to a genetic laboratory so that they can perform genetic testing. And then they can make sure that you have myotonic dystrophy. And what they will give you is the diagnosis. And in Canada, you will also receive the number of CTG repeat, which I told you go from 50 to 2,000 more. And the more you have, usually it will tend to be more severe and happen earlier. However, there's still a lot of what we call diagnostic odyssey, which means that before you receive the proper diagnosis, it will typically take over 7 years for myotonic dystrophy. And that was taken from a Canadian and US project. And this is probably less true in Quebec, because in Quebec, the disease is also more well-known by general practitioner and general neurologists, but still it can be even longer than that in other countries. So now, what are the signs and symptoms and treatment option? Because I will talk about the two together. So here's a very nice picture that shows the complexity of this disease. So the first thing that is very important to understand is that although it is called a neuromuscular disorder, it is a neuro-multisystemic disorder. It is not only muscular. Muscular in terms of muscle, in terms of arm strength or leg strength. You will have potential problem in every single system of your body. They will not happen at the same time. They will not happen with the same severity, but you have a chance to experience some or most of those signs and symptoms at one time or another in your life. So we'll go over all of those systems one by one. And here is the results of a large US and Canada survey. And what you see is the symptom prevalence of all type of myotonic dystrophy. So type 1, type 2, and congenital. And what you see, the top symptoms is muscle weakness, fatigue, daytime sleepiness, balance issue, myotonia, which is the difficulty to release your grip after squeezing it, muscle cramps and pain, and difficulty swallowing, and we go on. So it's really a multisystemic disease, and a lot of the symptoms up to learning difficulty will be experienced by more than 50% of the patient. In DM1, the top 5 problem reported by the patient was muscle weakness, daytime sleepiness, fatigue, myotonia, and balance issue. Now, as I've shown a few slides earlier, you can see again that depending on when you start to have symptoms, what we call age of onset, you will see that depending on your clinical phenotype, so from congenital to late onset, you will have different problems happening at different time. Now, I like to say that I will start from the end because usually we do the list of signs and symptoms. But today, I wanted to start from what does those signs and symptoms, how does it impact your life? And so here's the most frequent problem encountered in your daily life. This comes from a Canadian study that we did a few years ago. And what we see is that if you have the adult or late onset phenotype, you will have major difficulty. This is the most difficult one, with major household tasks, keeping work, maintaining your own, maintaining your yards, preparing meal, going to touristic activity, and having sexual relationship. Now, this was like a picture of the problem, and we also address how does it progress over time? Does it stay the same, or do you get more difficulty with time? And this is, I would say, a very kind of encouraging portrait. So we see that for nutrition, we have people that have improved 5% over 9 years, and people that have decreased their performance for 33%. For personal condition training, 12% improved and 55 decreased, which is expected over 9 years. And there was not a large progression, it was a small progression. Personal care, again, some people increase, some people decrease. Housing, this is a very interesting one, where you got 28% of people that have improvement in their ability to take care of their house, and we'll talk about that later, and 31 that decrease. Mobility, some people improved, some decreased. Community life, leisure. Now, this is the where more than 20% have improved, housing and mobility, and we'll see how it is possible in a progressive disease. And we have two things that have decreased a lot over 9 years, which was personal condition, which is training and keeping fit, and leisure. Okay, so the interesting thing about this research that we conducted is that trajectory of disease is different from everyone. And this is very important because here's your personal factor. This is how we envision participation in your daily life. So you got personal factor, and DM1 is one of your personal factor, but you can also your ability to be resilient, you got your ability to solve problems. You also have your environmental factors, so your family support, your healthcare services, the way your house is set up, and those two things interact together to make you able to do your daily activity like nutrition, taking care of yourself, dressing, and going to work. But what is interesting from that 9 years longitudinal study is that there is some power that you can have to change the trajectory of your disease in your life. It will not cure the disease, but it will improve the way you perform your daily activity and you are satisfied with this. So the first step is to be better able to manage your disease. And this is very important. And we have now more tools to help you to manage your disease than we did a few years ago. Recently, the Myotonic Dystrophy Foundation in the United States have launched a series of international collaboration to develop consensus-based care recommendation to treat patients with myotonic dystrophy type 1, type 2, congenital myotonic dystrophy, and different issues. And those guidelines are available on their website. And this is something you can even bring to your healthcare provider, that you can disseminate, and that there is a patient version, which is my clinic visit planner, which is really about, it's a tool to take to your doctor or to your occupational therapist or your physiotherapist, and to help you think about what I should not forget to tell them, or what should I ask if we'll see. Yeah, there's different issue where there's clear recommendation for annual evaluation. So then you can start asking for those things. So let's start with the different system. So the muscular system obviously is the muscle weakness. Here on the right, you will see little picture. They will come along all my presentation. And what you see is in orange is the overall prevalence of that problem. In green, congenital, DM1 in blue, DM2 in purple. And what you see is the total prevalence over 100%. And 12% here say that the muscle weakness has a small impact, 32% has a moderate, and 47 have a large impact. So it's always a gradient of color. And what you see for DM1 is that 34 and 41 said that they have a moderate to high impact of the muscle weakness on their daily life. So it is a distal to proximal patterns. So it starts in the hands and it moves up to the shoulder, or from the feet to the hips. The rate of progression is still not very well documented, but it's between 1% and 9%. So it's about the equivalent of the aging process, but the aging process may start at 20 years old in the adult phenotype. So that's the difference, but it's about like aging. It is very variable between phenotypes, sex also, and muscle group. So if you're a man or a woman, you won't tend to lose muscle strength the exact same way. Overall, you will not need a wheelchair for indoor mobility until a very late stage of the disease. But the most important point that I will come back is that there is a lot of fall in myotonic dystrophy, 10 to 50 times higher than the general populations, and 20 to 30% of them results in injuries that will further reduce your mobility and independence. And that is a very key point that will come back. Myotonia is not the most disabling aspect of the disease. As you can see in blue, 17% only said that there was a major impact, but it will have diffuse impact throughout your body, including gastrointestinal symptoms. So muscle strength is very important in explaining your current participation level in all your activity. What you can do is ask for a formal assessment by your rehabilitation team. Learn to see technical aids as a way to make things easier. What we see from a lot of interview with patients, clinicians, and family is that several of our patients has fought over for years not to use a walker or a wheelchair, but once they accepted them, they realize what they have missed in terms of autonomy. Because if you are at high risk of falling, if your mobility is really reduced, if you don't use those walking aids, you will further decrease your walking capacity, and that will keep you inside of your house, not in the community, not being able to see your friends, or too exhausted to do anything else, because all your energy has been moving to, has been given to walking. Keep active, you will see, but new Canadian study led by my colleague, Elise Duchesne in Saguenay, have shown the benefit of exercise training. So now there is a better recommendation that exercise is safe if it's agreed by your doctor and if it's done by a trained professional. And it's really important, and you will see later on in my presentation what potential benefit it can give. And nutrition is a key building block also to muscle strength, because muscle needs proteins to be kept in good health. And what we've seen is that with all the problems related to myotonic dystrophy, and we'll go that in a minute, people tend to eat very poor food choice. Walking issue now, very important. Keep fit, even more important than ever, because you need to keep your muscle mass. And we've shown that if you train, you will be able to keep your muscle mass longer. Keep your respiratory function without, like impacting your respiratory function, like by smoking, because it's highly related to endurance. So how long you can walk in the community. Physiotherapy, regular follow-up, walking aid, risk of fall, and all the environmental barrier inside of your house or outside can be assessed by the occupational therapist. It is not normal to fall. It is not normal to almost fall. You should avoid that as much as possible, and there's a lot of way to help you. Walking versus energy conservation, as I briefly talked to it. Better plan your community outing. Choose what you want to do. Do you really need to walk to go there, or can you use a wheelchair to be safer, more effective. And then once you're there, then you can walk and just, not use your wheelchair. Also, your community outing, if you is a trouble to walk a long distance, then several shop now deliver and shop for you, even more since the pandemic. Oops. Now, moving on to dysphagia. So this is the difficulty swallowing. We got between the different studies, say 20 to 80%. The Canadian-US questionnaire reported that 75% of DM1 patients have reported presence of dysphagia, and 70% were overall affected across all myotonic dystrophy type. So you will have difficulty eating specific texture of food. It is partly related to your muscle strength. There is issue over the gastrointestinal tract. It's also difficult to handling the cutlery, taking food in your plate. And as I said, poor choice of food because you have more difficulty cooking. So what can you do? And here's the alert sign. Okay, so it's very important that if you experience these symptoms, you talk to it about with your healthcare provider. Coughing often during meals. Stop eating certain food. Oh, I don't eat chips anymore, or cracker, or hot liquid, or apple. If you suffer from a pneumonia, this is very important because if you have dysphagia, you're more at risk to suffer from aspiration, which is like the liquid will not go into your digestive tube, but to your airway, and that can provoke pneumonia. And there's a lot of underreporting from the patient population. So you really need to be aware of those alert signs. There is a lot of intervention on dysphagia that can be done. So you can work with your nutritionist, occupational therapist, and speech therapist. You can adapt the texture that you are eating. You can also prevent choking with the Heimlich maneuver and learn about the best position you need to adopt while eating. And there's a very recent nutrition guide for people living with myotonic dystrophy that has been posted on Myotonic Dystrophy Foundation and is done by 3 highly knowledgeable nutritionists on DM1. What about meal preparations? So this is also important because as you become weaker and your hands doesn't function as much as they used to, it will be harder to do meal preparation. This is a key issue as disease progresses and you are getting older. Maybe it's time to think about modify your role during meal preparations. Use pre-cut vegetable. There is great delivery solutions now with cook. I'm not promoting any of those, but I'm just saying there is a lot of issue. And what I always tell when I give conferences, usually to patients, what I say is really about thinking about seeing it as a way to take your time to more meaningful activity. So what I say always is I use it, I love it, and I'm helping the economy because if you're using pre-cut vegetable, there's someone that has cut the vegetables. So that means that there's more, work that is done. And right now it's very trendy as well. So a lot of people without any hand trouble will use those kind of solution to, save time. So you can see that as well as you're saving time to do things more meaningful. And grocery. So several grocery stores now can prepare your order in advance and can also deliver it to you. And so that's another good solution to save some, if your endurance in walking is not as good or your balance, this is a good solution. And especially during this pandemic, then it's also a good way to be safer. Now, another point that is important is gastrointestinal symptoms. So a lot of patients suffer from diarrhea, constipations, and really there's not a lot of studies describing it. But what we've seen from a recent ongoing study that we're conducting with one of my students in physiotherapy, is that it's really present in the DM1 population, and it's really, really impacting their daily life. So patient will say that they will not go outside as often because they are stressed about having episode of diarrhea. They will not go outside because when they have constipation, they have a lot of pain. So that will prevent them from going outside. And so a lot of people are suffering, and hopefully we will have more data very soon to make sure that we start thinking about more options. There is some treatment that can be tried out by your neurologist, your gastroenterologist, if you're lucky and have one, or by your nutritionists or dietitians, so that they can give you trick about the food that you eat that can help with diarrhea and constipation. But please, a lot of people don't report, especially diarrhea, because a lot of patients feel ashamed of having those symptoms. You know, it's not fun to say, oh, I am swallowing my panties. Well, please do, because there's a lot of patients, 58% of patients actually live with those issues. So it is not something uncommon, and your clinician will be very keen to help you to find the best solutions. Now, central nervous system, so your brain. So there is definitely issues with, so the myotonic dystrophy also affect your brains. If we talk about congenital myotonic dystrophy, then it is very severe. You will have intellectual disability associated with congenital myotonic dystrophy, which is when you're a baby. But when the symptoms happen later, then it affects also your brain, but in a different manner and less severe. But what is really important is that there's two things. There is the apathy. So the apathy is the lack of initiative or inactivity. So you know that you have to do something, but it's so hard to get out of your couch. Oh, you feel like you're bored, but it's complicated to call friends or to organize something. You want to do things, but when it's time to do it, you don't feel the drive to do it. So there's more than 40 to 50% of patients that do have what we call clinically significant apathy. So it's not just something that one day we don't feel like doing anything. It's about every day that you don't feel like doing anything. And this is not something that is like specific to you. It's really specific to a lot of people with myotonic dystrophy. And the other thing that is important is this executive function impairment, which is a neuropsychologist term. But what it says is that those symptoms can lead to great difficulty in planning and organizing one life, affecting such as areas paying bills, keeping appointment, and arranging schedule. Something is broken in your house, and it will be very difficult to organize so that someone can come in and repair, because you're not sure about how to do it, or if there's different problems. So it's difficult to resolve problems. But again, it is a symptoms of this disease. So you need to talk about with your rehabilitation team about how you can best circumvent those problems or be helped by your significant other. The other thing that is important with that, it's what we call health literacy. So when you talk with your doctor, with your social worker, or with your neuropsychologist, it is difficult for you to understand all the concepts related to health, all the specific terms, all the things that you need to do. And this is also very common in myotonic dystrophy. And what we do often at our clinic is that we gave adapted recommendation for our patient. So it's easier to understand, and it's easier also to remember. But don't be afraid to ask more questions. Say, okay, sorry, I don't understand. It's not clear for me. I need more explanation, okay? Because if you're not able to understand properly, you will not be able to manage your disease properly. And you're the key person. You're with yourself 100% of the time. As an occupational therapist, I was probably with you 1% of the time. So you need to be able to manage your disease and get efficient. The other thing that is there is the fatigue. So this is a key factor that we found in different studies that explain your participation level in all of your area of your life. And it's not a usual fatigue that others experience. It's not like today, I am submitting a big grant. I am very tired because I have not a lot of hours of sleep in the last week. I am tired, I am fatigued, but in 2 days, I'll be okay. So that's usual fatigue, you know, but you have what we call central fatigue, which is really related to your brain functioning. And this is 90% of patients across all types that will suffer from fatigue. So you need a formal assessment by your medical team. You need to have energy management, keep the most meaningful activity, adapt your activity, be inventive. And it's the energy of all your families, so plan it together. There is medication that can help, and nutrition is also a building block. Hypersomnolence is a little bit different. So that's where some people will go to bed at 10 o'clock at night and wake up at noon every day. Again, this is not something in your head. This is really related to the disease. And again, medication can help. It can also progress over time or stay very stable. And there's a lot of, and medication can really help for a lot of patients on this issue. Now, a little word about right now. So a lot of our patients and in the general population have found that they're more fatigued. They don't feel like doing as much as they used to. So they have more apathy. And it is very possible that you're experiencing an outburst of that. And it's really, it's been explained by some of the researchers and clinicians as it is called what we call occupational disruption. So every day, I mean, when I usually go to work as I used to, well, I had to get my lunch ready, I had to get dressed, I had to brush my teeth, I had to feed the dog and go out, let's say. But when I'm at home, oh, am I going to dress today or can I stay in my pajamas? Should I eat right now or could I eat later? Oh, well, I don't know. Well, I can start also maybe to do a, some cleaning of the house before I start working. So our days were not the same every day. There was a lot of decision to make. Our routine has changed. And this requires a lot of energy. And especially in the neuromuscular population, you had we heard a lot about service disruptions, problem getting your personal help at home, being afraid and rightfully about getting sick. What are you going to do if you happen to end up in the emergency unit? So there was a lot of that. So that can happen. Respiratory system, not pneumonia. This is the most frequent cause of death. What you can do is getting your vaccine on time, being assessed for dysphagia to make sure that there's no water or fluid that goes into your lung, smoking cessation, and of course, be extra cautious during this pandemic. Cardiac system is the second leading cause of death. Usually it's very silent. You don't see it. The only thing that you need is you need to have your annual ECG evaluation done at your clinic, even if you're asymptomatic, even if you don't have very few symptoms of myotonic dystrophy, you just have cataract and a little bit of myotonia, doesn't matter. You may be very involved in terms of cardiac issues. So please really do have your ECG every year. Second thing, very important, anesthesia is possible in myotonic dystrophy, but you really need to talk to your healthcare provider, so your doctor and the team that's gonna sedate you, so that you make sure that they know that you have myotonic dystrophy and they know that there is specific guideline for those anesthesia. And there is a quick reference guide for anesthesia as well on the MDF website, so that you can really bring that to your healthcare provider. Now, We recently completed a study interviewing patients and family about what is helping them managing their disease. And what they say as major facilitator with disease acceptance by the patient and the family, get help. So get help because it's hard to accept the disease. And so you may need to talk about it to a specific, with your loved one or also with professional. And it may be variable with time. You don't accept the disease at the same level every time because sometimes you have lost. And when loss happens, it's harder to accept that you have this disease. Use of technical aid is very important. And long-term management with the same medical team was also highlighted by the patients. Physical help from the family, motivation and psychological support from family and friends, and service proximity. So if you have to move to a new house, well, start to look at, is that area where you want to move is rich in services or is that very far from services? Because that's another key issue. Barrier. So, okay. So this is, snow was identified, but this was done in Saguenay. And this is a picture of my house in a very particular bad winter. So we didn't see the street as there was so much snow. Fear of falling is a barrier. So discuss with your PT and find solution. There is solution. Stigmatizations, loss of the driving permit, apathy. So the apathy, the difficulty, to get going, and lack of support from family. Now, I hope this was clear, and I know it was a very short overview. And now we're going to move on to the Canadian Research Project. And I'm saying it is an incomplete overview because if I was going to present all the project, it will have been a name-dropping session. And I think I've just highlighted some of the key area, but just so that it makes, it makes meaning to you. So the first one is obviously what Amira has talked before, which is the Neuromuscular Disease Network for Canada, which is a large pan-Canadian initiative under the leadership of Dr. Hans Lockmiller from the University of Ottawa. And we really focus on helping to improve clinical services to the general neuromuscular community, improve research capacity and clinical trial readiness, so that if there is clinical trial, we'll be able to bring them to Canada and to offer them to our patient population. We have a few examples. So there's different things that you need to know. So first you need to understand the disease, because if you want to treat them, you need to understand them. So there are several researchers involved in Canada. I've highlighted Dr. Christopher Pearson because he just recently, like 2 days ago, gave a great talk with other international researchers. So you can have his talk at the Video Academy if you want to learn more about the physiopathology. Dr. Bernard Jasmin is in Ottawa. He's working on mouse models. So he's a step further. He's looking at muscle function and what is influencing muscle function in myotonic dystrophy. The other thing that we need to know is, where are the patients? Because if there's a clinical trial, the pharma company is going to ask, how many patients do you have? How many patients do have hypersomnolence? Because I've got a drug that treats hypersomnolence. So what you need is registry. There's 2 large registries for myotonic dystrophy in Canada, the Canadian Neuromuscular Registry, led by Dr. Lawrence Corngut, and the DMScope Registry, which is a Quebec, France registry that is recruiting patients from Quebec and France. So 2 different ones, 2 very important ones. A few more examples. If you want to be able to tell patient, this is how long you're going to be able to walk, this is how long you're going to be able to do this and this, you need longitudinal studies. So you need to reassess patient over time. And so there is a lot of ongoing longitudinal study. And with that, usually you have also biomarker identification. So what biomarker are really something in your blood, a protein or other things, that tells us that, okay, those patients are doing better if this protein is more elevated, let's say. And if we identify this, if we have a therapeutic product, then we can see is that increasing or decreasing that protein. So that's very simplified, but let's keep it that way. So Dr. Craig Campbell in London is working with US partner for the congenital myotonic dystrophy longitudinal study. Dr. Hans Lockmiller is involved in a lot of longitudinal study on myotonic dystrophy and biomarker identification. And myself and the group, the GRIM or research group is working on longitudinal study with researchers from Quebec, Montreal, and Saguenay. Now, I'm going to give you in the next 2 minutes a few examples of what we mean. So I'm going to talk about 3 studies that have happened recently in Saguenay, and we were targeting muscle. So the first thing is that we have a longitudinal study with myotonic dystrophy patients since 2002. We assess patients over time. And recently, what we've been able to show in 2015 to 2019 was that over a 3-year period, only sedentary patients have lost walking endurance. So the patients that were doing training or very intensive training, so there was 2 types, they didn't lose significantly walking endurance as sedentary patients did. So when I said at the beginning to keep fit, this is why it's important. It will not stop the disease, but it will help to decrease the progression of the disease. And what we did is we also took muscle biopsy. So this is a muscle cell, and we took a little piece of it with a needle. And I'll go back to what happened with that. So what we did is that we did also a training program for men to start with a 12-week training program. And what we've shown is that our patients have improved over a 12 weeks program on the different exercise that they were performing. And what we show with the muscle biopsy is that it was safe, so we were not destroying anything. And some of the patients actually expanded their muscle mass, and the biopsy was better. We also shown, and we're just publishing this, is that overall participating in that research program of exercise was decreasing your level of fatigue, and that the impact was lasting over a 9-month period. And the same program is going to go on for women in 2022. We were stopped by the pandemic, so that was sad. We also have a longitudinal study on cognition over a 12-month period that will help to inform trial readiness. So is there anything that we can capture that is moving, that is decreasing over a 12-month period? And the other thing that is very interesting is a Quebec, France study that we just finished on the infantile phenotype. So that's where you start to have your symptoms between 1 and 10 years. And we look at the ability for autonomous living and its relation to cognitive function. And we keep going with the 2 Muscular Dystrophy Canada 2021 recipient were on myotonic dystrophy. So both of them were on stem cells and iPS-derived neurons. So 2 very fundamental projects. I don't know much about this one, but I know about this one because I'm working very closely with Elise and Nicola. But what they are looking at is really a new therapeutic target for muscle impairment. They are trying a therapeutic product that could help resolve the muscle impairment. So not the whole disease, but at least the muscle impairment, help to decrease muscle strength loss. Now, I just like to thank all of my partner at the GRIM and our patient partner that are with us at every step. They're very important to us. And just after the conference, I am talking to them because it was the International Myotonic Dystrophy Day. And this is some of the funding organizations that were part of the research result that I've shown you. So now I will stop my screen share and I'll be ready for the questions.
Questions. Thank you so much for a very clear, engaging, and insightful webinar. I can't tell you the number of comments that I received throughout this webinar on how wonderful and how informative this was. Thank you for summarizing research in a plain language manner, and we really appreciate it. So let's go to the questions in the remaining time. Can we get a diagnosis without EMG? So if an individual only had genetic testing, is that enough, or should it be complemented by EMG as well?
Yeah. No, if the genetic testing is done usually it's like a clinical path that they all follow. But if they have the genetic testing, then that's fine. That's the only thing they need. But usually it's because you have a large choice of potential disease and you don't want to order those genetic testing for, just in case. So usually you refine your diagnosis until you have a few possibility, and then you order the genetic testing. But if you have genetic testing, of course, you don't need anything else.
Very good. Another question/comment. We've seen a few comments here that it is difficult to deal with the apathy piece that you talked about and the loss of drive. And whether you've had any suggestions on managing that, or can expand on how to manage the apathy piece.
Yeah, it is, of course, very difficult. There is not a lot of solution right now. Some people may respond to fatigue treatment in a different way. So if you're going to your neurologist or your treating physician and you talk about you're not fatigued, but you're apathic, then they may try the same kind of medications and it may help. The other thing is that we are working right now, thanks to MDC, with Benjamin Gallet, which is a specialist on apathy, and he's actually looking at a qualitative study. So he's trying to understand apathy from the patient perspective and from the family perspective, and try to get the best way to get people out of their apathy. And one thing that they are trying right now, I think it's in France, it's cognitivo-behavioral therapy, which is a therapy that sets goals. So you're having a to-do list, a goal, you got recalls, things like this, and they're trying to see if that can come across the apathy piece, which is a very hard one also, because it's a very it's not obvious. It's not a broken leg, it's something that it's impacting your life, but that doesn't show in front of people. So you may feel that you're lazy, that you're not, and having drive right now is a highly valuable thing in society, being a drive person, driving, I don't know how to say it in English properly, but yeah. No. So I think that, but it's very important to recognize that as a symptoms of myotonic dystrophy. It's not because of you, it's because of your disease. Now, and what I'll make sure is that Amira will lead to Benjamin so that maybe he can give a talk at one point on those issues.
That would be wonderful. And I have to just say, just to add on to your point, some of the comments that I'm seeing is to say, because of this webinar, they are feeling validated in their symptoms or experiences, especially the ones that don't get talked about a lot, is what I'm seeing around apathy, drive, but also gastrointestinal. So they really appreciate that you touched on all of those points, because it helped to validate their life experiences. So I appreciate those that have put that in the comments. Question for you, and this is probably pulling from your occupational therapy background. Any exercise recommendations for myotonic type 2 in the home without much equipment?
Yeah, there is I'm not a specialist, but there is a guideline that is available on Myotonic Dystrophy Foundation. I think it's for type 1 and type 2. And they give very clear exercise. They give exercise program. The other thing that we are conducting right now, we're trying it with a patient population with myotonic dystrophy type 1, but I think it will apply to type 2, is a home-based program that is all remote, that has been designed for another population can recall, but we adapted it to myotonic dystrophy, so that and it doesn't need anything except a chair and a mat, and that's it, and the rest is like other things. So yes. So I will send you the recommendation for that.
Yeah, if you can send me that, what I can do is after this webinar, I'll send all participants a survey to let us know your thoughts about today's webinar, but I'll include that resource as well. Another question is about, and I see it, there's also in the Q&A, but a similar question is that many clinicians are not aware of myotonic dystrophy. There's many clinicians are not familiar with myotonic dystrophy. So you might see in the Q&A, there's a question specifically about perhaps a clinician in Ontario who specializes in myotonic. Do you find that this is the case in Canada, that that clinicians have not as much knowledge? Is there
I think that in Quebec, generally speaking, clinicians are more aware of myotonic dystrophy, but this is because of the higher prevalence. So there's more, but even then, I mean, I just recently have a little boy that hasn't been diagnosed for so long. I was like, oh my God, no, but I mean, if you know myotonic dystrophy, it was clear he had myotonic dystrophy. But in the school system, it was not picked up until a long time. So he was diagnosed as everything else but myotonic dystrophy. And then finally someone just come, oh my God, this is it, So this is not uncommon even in Quebec. I think that what we are trying to do with NMD4C and Muscular Dystrophy Canada is to try to empower the patients and their family to educate their healthcare provider. And I think that if you find out your health, first, if you don't have a specialist in myotonic dystrophy, I think the best resources is Muscular Dystrophy Canada, because they can help you to find a good resources for myotonic dystrophy. The other thing I think that will lead the way forward in the next few years will be the tele-readaptation, or the how do you call that? E-consultation.
Yeah, like telemedicine or
exactly.
Virtual medicine.
So that the patient doesn't have to drive 3 hours to go see a specialist. And oftentimes, for a lot of the symptoms, you don't need to touch the patient. I mean, for fatigue, apathy, executive function, you can order the test locally and just receive, your blood work, your GI evaluation. That's not done by the neurologist, or by the expert team. So I think that that's something that deserves to be further thought out by the Canadian specialists, so that we offer more services to to other part of the country.
That's a great way to end today's webinar. Thank you so much, Dr. Gagnon, for once again an informative webinar. This is a great way to celebrate International Myotonic Dystrophy Awareness Day. Thank you. All the best with your CIHR application. And to those who are on the call today, I will follow up by email, but you're always welcome to send any questions to research@muscle.ca. Thank you all for joining today. Take care.
Bye-bye, and thank you for having me. That was a pleasure. Bye.
Thank you.